It is my great pleasure to welcome Assistant Professor Dr. Lalit Agrawal sir, Cataract and a Vitreoretina specialist. He will be presenting on the topic that is both critical and highly relevant, PCR management, tips and tricks, sharper vision, deeper insight, the subspecialist approach to cataract.
Good afternoon, everyone. I would like to thank the part of Ophthalmic Society for giving me the opportunity to talk on this topic. I have no financial disclosures. However, I would like to disclose that the videos are not mine. I want to be safe that I have not done all this PCR. And also to add on, whenever we talk about PCR, we normally tell, okay, this is a video of one of my junior or one of my resident. However, I think that is not the condition. The incidence of PCR is around 0.45 to 7.5%. There is a lot of variation. Yesterday itself, we had a journal crop on PCR, and it was seen that PCR was not associated with the experience of the surgeon. Lots of questions. I requested them to share some of their questions. These are not all questions. So I expect, or I have tried to cover some of these and some of the questions which have been raised. However, we can discuss on the topics or the questions which has not been covered in the presentation. The most important part of PCR is we should predict the disaster before the surgery is. In terms of equipment, especially if you are not familiar with the equipment, it may be the microscope or the phaco-immersive representation. Extraocular factors like prominent eye probe, deep-seated eye, we should be extra cautious in those cases. Ocular factors, reduced posting factors, we are aware of commonly like post-polar cataract, post-intravitreal injection eyes, previously vitrectomized eyes, post-trauma, or even PCR in the other eye. Most important again thing is intraoperative prevention. When we are constructing the wound, if we are planning to use a 2.8 mm phaco probe, let's not make a 3.2 mm incision. It will lead to leaky wound and a shallow AC, which itself is a risk factor for PCR. If you are having an extension, runaway axis, let's not pull it. Cut it and proceed. When we are doing hydrodissection, let's not inject lots and lots of fluid. It can lead to blowout of the posterior capsule, especially if the AC has been filled with lots of visco, or if there is a small CCC or a small pupil. While doing nuclear management, we should be careful that the phaco probe is not very close to the rexis margin or the posterior capsule. And while doing irrigation and aspiration, we should be very careful when we are doing sub-incisional cortex aspiration or when we are very close to the posterior capsule, especially when doing capsular policy. Nuclear management and irrigation and aspiration are two steps in which most of the time we encounter or we detect PCR. Let's have this video. We'll be seeing this video once again. Let's focus on this area. While doing an epididymis nucleus removal, there is PCR, sudden deepening of the antechamber, pupillary dilatation followed by pupillary constriction. Pupillary snap sign, and we continue the phaco. Let's not continue phaco once we have detected or we have got a clue of PCR. Clues can be in the form of localized brightening of red reflex or pupillary snap sign as seen in that video, or if there is PCR occurring at the time of nucleus management, there could be immobility of previously mobile nucleus, excessive lateral mobility of the nucleus, excessive tipping of one pole of the nucleus, movement of intraocular structure with the movement of the instruments, or there can be peaking of pupil towards the end of the cycle. Most important thing is let's not panic. And there the known early responses which we have been reading since our residency: avoid sudden removal of instrument, lower down the water height, stay in foot pedal 1 and fill the antechamber with viscoelastic. We all know this, but I think many of us still don't have that reflex whenever we encounter the PCR. The next step is to assess what is the size of the tear, what is the stage of phacoemulsification, and what is the stage of hyaloid phase integrity. The goal of management of PCR is to avoid extension of the tear, to avoid capsular axis damage, to avoid drop lens matter, minimize the traction on the vitreous, remove the remaining lens matter, and IOL implantation in the right position. We'll be discussing on some scenarios. Scenario 1, the size of the tear is small. The stage is all the lens matter including the cortex has been removed and the hyaloid face is intact. I don't know how commonly do we encounter, I have encountered it very rarely. In this stage, there is not much things to be done. The PCR, if you are confident, a primary posterior capsulotomy can be done, followed by IOL implantation in back. Coming to scenario 2, where the stage of the nucleus emulsification has been done, however, the cortical matter is still remaining. The size of the tear is small. So what do we do now? We keep having this question: how to remove this cortex? If the hyaloid is intact, the immediate response will be to occlude the PC defect with a cohesive viscoelastic and then continue with the dry aspiration. In this video we can see there is wrinkling of the capsule, posterior capsule, giving an indication that there is a PC defect. Viscoelastic, lots of injected, you can see it is extended here. However, we don't expect a vitreous prolapse and we can go ahead with the Simcoe to aspirate the cortical matter. Repeated filling of the antechamber with viscoelastic is important to prevent AC collapse and vitreous prolapse. Another thing is you should be very careful while injecting visco. Lots of visco injection can lead to extension of the PC defect. So a very graded amount of visco, maybe it comes with practice, should be injected so that we have the AC maintained and we prevent further extension of the brain. Another technique is bimanual irrigation and aspiration to remove the cortical matter. In this video we can see epinucleus removal is being done using the phacoemulsification. And as we are trying to remove the last part, suddenly we see that the lens matter is not coming towards the phacoemulsification. Loss of followability, which itself is an indication of PCR with vitreous defect. So vitreous is in AC, as per early response studied during our residency time. We fill up the AC with the viscoelastic, go ahead with staining of the vitreous with the triamcinolone, followed by anterevitrectomy. Once we have vitreous prolapse in the antechamber, we should not do anything other than anterevitrectomy. Anterevitrectomy should be done, all the prolapsed vitreous in the antechamber as well as up to the posterior capsule should be removed. We should be sure that all the vitreous has been removed. Now we can go with irrigation and aspiration cannula and remove the cortical matter starting from the area away from the area of PC defect. Another technique is the vitrectomy probe cortex expression technique. This is a technique I choose over the bimanual irrigation and aspiration technique. Here you can see there is irrigation and the vitrectomy probe. I will do an anterevitrectomy first to remove all the lens or the vitreous in the antechamber, followed by removal of aspiration of the cortex from the area away from the area of PC defect. Once we have brought it to the center, I cut it again, aspiration, cut. In between, if we have a vitreous prolapse, we go into the vitrectomy mode, do a vitrectomy. The rate of vitrectomy should be kept as high as possible, and the vacuum could be around 150 to 200 ml/month. Care should be taken that the entire vitreous has been removed from the anterior chamber and the capsule. I preferably check for any vitreous in the wound at the end of the surgery. Scenario 3, if we are having PCR in stage of nuclear management. Whenever we come across PCR in nucleus management, we just don't want the nucleus or the lens matter to drop down. So we are in a hurry. I normally, if there's a lot of nucleus remaining, I would convert it to a manual small incision cataract surgery and hurry with the removal of lens. But before that, we should make sure there is no vitreous in the anterior chamber surrounding the nucleus, because there will be lots of traction when we are removing. So either convert into manual SICS or continue with phaco is a question. We should stain the vitreous whenever we encounter this. Let's not be so scared. Normally, the lens does not drop into the vitreous cavity. We have a fear that the lens will drop if I don't hold it, but actually, if it is not a vitrectomized eye, it will not drop. So in this video, you can see there's lots of vitreous in the anterior chamber with vitreous in the wound. Even in this case, if we go ahead with conversion immediately without doing an anterior vitrectomy and removal of nucleus, lots and lots of traction will be created. Next stage is we have either multiple nuclear fragments or there will be a last fragment. What do we do? Again, we can convert into the annual small incision cataract surgery, or if we are confident and the vitreous space is intact, you can continue with the phacoemulsification. But care should be taken that the PC defect has been occluded using a cohesive viscoelastic, and care should be taken that AC does not collapse while doing phacoemulsification. And preferably, it is better to use a scaffold to prevent vitreous prolapse into the anterior chamber or drop of nucleus. In this video, we can see there is a PC defect, triamcinolone assisted anterior vitrectomy is being performed. And in this video, contact lens, bandage contact lens is used as a scaffold. It is injected, the nucleus is brought anterior to the contact lens as the contact lens is unfolded. After that, the lens which is anterior to the contact lens can be emulsified, followed by removal of the contact lens easily with any instrument. Then we can go ahead with the anterior vitrectomy and cortical matter removal. Another scenario can be an impending nucleus drop. Whenever we come across such a condition, we have lots of things in our mind. What to do, whether the lens will drop, how will I manage, do I have a vitreoretinal surgeon in the same OT or in my hospital? Let's not attempt to bring back the nucleus into the anterior chamber if it is already in the anterior vitreous or mid vitreous state. Only if it is in the back, and if the one of the pole is tilting, we can make use of Sinski hook or even a chopper to get it back into the anterior chamber. And then we can manage the way we just saw. In this case, we can see, in spite of PC defect, we can see this lens matter. There is no followability of the lens matter. Still, we are trying to hold the nucleus. We could not, and the nucleus dropped. This attempt actually causes lots of traction into the vitreous base and can lead to lots of problems later on. If nucleus drops, no fishing. Remember, lens matter does not cause vitreal break. The traction causes. One way could be we can take help of a vitreoretinal surgeon who can do cortical removal, anterior vitrectomy from posterior approach. Using an instrument, we can get it to the anterior chamber, the posterior assisted levitation. We can also use a 3-piece IOL as a scaffold, which can be injected into the anterior chamber. then phacoemulsification can be continued the same manner as we do it, but in the anterior chamber, followed by implantation of IOL in the sulcus. Whenever we are doing phaco in the anterior chamber, we should take care of the corneal endothelium. We should at least keep that in our mind. IOL implantation, simple. It's posterior, small capsular defect. We can go ahead with implantation of IOL in the back. One thing should be taken care of. If we are planning to implant the IOL in back, let's not use 3-piece IOL. 3-piece IOL actually causes lots of traction at the area of PC defect and can cause extension of the PC defect. So, IOL implantation in the back in case of PCR should be a single piece follicular IOL. Large PC defect with an intercapsular intact intercapsular ring, 3-piece follicular IOL implantation in sulcus is the best way. Here we can see 3-piece IOL is being implanted in the sulcus. Whenever we are implanting such 3-piece IOL, if the pupil is small, many of the time we have a confusion whether it is in the capsular, in the sulcus or not. We can take use of a second instrument to retract the pupil and confirm that the leading haptic is in the sulcus. Once the leading haptic is in the sulcus, it's a very rare chance that the trailing haptic will go in the vitreous cavity. Also, after this, a pupillary capture should be attempted. The size of the rhexis is decent one, smaller than the optic, a pupillary capture should be done. If there is no capsular support, ACR implantation, iris claw lens implantation, or a scleral fixated intraocular lens implantation can be done. To summarize, whenever we come across such a condition, we should remember the goal of management of PCR. Thank you.